If I go to calibrate now, I press here and be sure to leave zero flow. The machine is not running, and we go to next. So now just wait for a short while. See if the calibration is all right. Close. And there's also possible to do a system test. It's already been done. All lights green here. If there's one yellow light, sometimes if the battery is not high up, it's 91% now, so even that is green. Everything's green, we're happy. So then we go to ventilation. Now, this is the SIPPV setting. Before I do anything now, I just shortly demonstrate to you the CPAP setting. There's a flow 8, PEEP of 5, put the PEEP on 6. The back off is now turned off, so nothing will happen when the back off is not on, even if there's a P maximum set of, let's say, 15. If the backup is not on, it will only give the normal CPAP, and then you need a different tube set, and that's it looks like this: small prong, small mask. And I try to explain in the lecture on Tuesday, Wednesday, that unfortunately we don't have the correct tube sets, and if we get lucky, maybe I get 2 or 3 of those when my wife is coming. So I'm trying to make some negotiations with my department. Maybe they send some.
And your wife, so you have to negotiate together.
Yes.
She carry everything.
So we will not do the CPAP right now, but if we had the tube sets, we could take off the flow sensor or leave it on, and then to put on the backup. The backup, if it's 1, and if the apnea time is 6 seconds, let's turn up to 8 seconds. Then after 8 seconds, the machine will give an extra backup once. If we turn here, it will give twice. And just to it reminds the baby of breathing. Baby's just not breathing, and the machine just and it will help the baby breathe again. So it's for an immature baby that needs some extra backups. So I think I will not make the CPAP function so much more complicated now until we are sure we get the tube sets. We did try to the other day to attach this tube set, and when we are cheating, we are actually able to plug it together, and maybe it will work, but I'm not quite sure because they're all tube set. Okay, shall we go to SIPPV now?
Yeah.
So what's the S for? Synchronized. So the machine will synchronize with the patient's breathing. And you see, nothing happened yet, because I did not yet press on start. On the previous, on CPAP, if we want to start treatment, I would press here. But I won't do now because we have an intubated patient. We can't put an intubated patient in CPAP. Then we need mechanical ventilation. So we go to SIPPV. And we have the PEEP of 6. Let's keep it there. Inspiratory pressure, let's put it on 19. 20 is average, 23 is much, 17 is not much. So
This one is the PIP, right?
So that's the PIP, correct. Inspiratory pressure. And the flow, there's one inspiratory flow, one expiratory flow. They're both on 8 liters. That's okay. Don't make too much out of this. As long as the flow is on 8 to 10 liters, it's okay. The trigger volume, if the patient is breathing, trying to breathe, and not very strong, we can put the trigger even more down. So the patient won't need to do so much and he will have some help. So a low trigger right now, but average trigger maybe 10-12%. And frequency 40 per minute. The inspiratory time, let's put it on 0.35. How high is it normal to go in inspiratory time in a neonate? Between 0.3 and 0.4, 0.45. But you don't put an inspiratory time at 0.7 on a neonate. That's too much. So 0.35 is fine. And now this trigger limit is off. So now we press start. Let's see what happens. So you can see the machine is giving 40 breaths per minute. Patient is breathing. You will feel it right here.
Yeah, I feel it.
It's moving.
Loud.
And the patient apparently is sleeping, doing no efforts to have any more help. So the machine is now breathing for the patient. Patient is intubated, let's say, is receiving morphine and sleeping and stable. So if you just intubate the baby and now stable, you would need to check the thoracic X-ray, see tube is in the right position, and then to take a blood gas. That's what you do. But to the ventilator again. If the patient is not satisfied with 40 per minute, wants more help, you will see every time the patient is breathing, the machine helps him. Here. Now taking a break. The machine helps now. Now the baby is breathing a little bit again, extra. Every time the baby is trying, then the machine is helping him. Yes. So even if he does that, like this now, the machine will help all the time. As soon the machine will alarm because the machine thinks the patient is breathing too fast. Maybe you should change your setting. Maybe you should change the setting up to, for example, from 40 to 60 per minute, if you understand. So frequency too high. What shall we do about that? We need to go to the alarm limits right here. We find the frequency, yeah, there it is. Patient is breathing 50 per minute, more than 50 per minute. So we need to turn up that alarm limit. It's turned up to 65. The alarm disappears. Okay? So
for like the SPPV, we not
SIPPV.
Yeah.
SIPPV.
We not paralyze the patient, right? Definitely.
You mean you don't for the intubation?
Yeah.
That has not really got to do with what kind of mode you are choosing on the ventilator. The paralyze for the patient is only for the intubation. But you are speaking about a long-term paralysis. We don't do that in the neonates. Let the baby stay drowsy on morphine and independently breathing, and the machine will help the patient just as much as the patient needs it. So we don't we do not do a long-term paralysis on neonates on a ventilator. Maybe only flying in a helicopter from one place to another. We give some Nimbex or a long-acting muscle relaxant, but not inside the NICU. That's only at the incubation. Did that answer your question?
Yeah.
Yes. So, good question. No paralysis, no muscle relaxant as long term. So here we have a blood gas. Right now the patient is breathing independently, but trying to have more help, and SpO2 is falling to 88. What will you look at? What would you check now? If SpO2 88, what will you check? So how much oxygen is the patient receiving right now?
SpO2
Only 8.
So here.
31.
So of course there's something to do there. You could take it up to 30 in the first place and see if the SpO2 here, and you see, yes, it's going up, 92, and it's a full-term baby, breathing, wants to breathe 60 per minute, and not really, he's intubated on 30, maybe 35% of oxygen now. No?
Start from the lower first.
I wasn't looking, but I was changing.
You change the mode.
SIPPV. So we're there. So the FiO2 is on 35, and SpO2 still falling to 91, 90, 89, and our patient is really struggling, and had a meconium aspiration, and we are escalating the pressure here. This is not much, but let's say we already had it up on 24 and a frequency of
How high up like the pressure or like pressure?
24, 25 is pretty high. If you need that, then that's a sign the patient needs quite much help, really. Now, frequency of 50, pressure 24, so that's quite much. And if still the SpO2 like 90, you need to escalate the FiO2 40, 45. So we have done that, and you already started on your antibiotics and taking your blood cultures, and still you're worried now because leak too high. That's the leak. It's most likely because of the high frequency. Let's see how much it is. No leak at all here. I didn't realize. I think I'll leave it on 50 and see if we're just able to. So we are on SIPPV, much oxygen. Want to help the patient even more. What can we do? Do you remember what we can do if we have patient already on conventional ventilation and want to give even more help?
Oscillate. Oscillation.
Oscillation. Yeah, so we just try oscillation. This is a very quick course. You will not learn everything today, just so you've seen it, right? So we want to try the oscillator, HFO. So now comes the suggested pressures. Map of So let's put it up to 13. That's moderate. Frequency of 10 per second.
Yeah.
The amplitude of 10. That's not much. So, but we
20 to 30.
yeah, we start now on first on 20, and don't care so much about that.
Frequency.
And now we have everything in place. We start. So is the bacterial filter connected to this adapter? Yes. So let's see what happens. So to look at the patient, and if you if you see now, the amplitude of 20 is not much, and you will maybe not see the SpO2 still only on 89, and so this peak pressure is too high. Turn out, we want to adjust the alarm limits, but first we take up the amplitude. Let's say slowly, 27. The patient was shaking even more. 30. There you go. Now, just show you what we will not do. Not like that. Just slowly up, carefully. 30, maybe 31, and see if the patient is shaking, and then to adjust the alarm limits here. So, what's the problem really? Because this peak pressure limit is too low. Nice. I'll take it up to 40 then. We went up to 33, 31 here, and here the map pressure is already on 13, so we need to take that higher up to 15, 16, 17. So now it will stop alarming. These things you have to practice. You can't remember all that. So if the machine is alarming, let's see here. So now, see what happens.
What is the indication to use like oscillation?
Oscillation. When you're not able to reach your good SpO2 or to open up the lungs using the conventional ventilator, then you try to go to oscillation, because it's more effective using not so high pressures, and you run the dog to try to get rid of the water. It's like trying to get rid of the water in the lungs, the amplitude to shake it off and to slowly expand the alveoli. Try to think that way, and then you have some. I'm quite disappointed it doesn't alarm now, because I was hoping the leak would have the machine alarm. Just try to make it bigger.
Anh vừa đang ngồi như này.
Still not alarming. Still not alarming. Let's see what happens if I take it off. So disconnection. Okay. The machine didn't like that. That's good. So we need to reconnect and just to check for the alarm history if we want to do that. So here. the log, you can see all the alarms that have been.
จะได้อัพมาได้ปกติจะมันจะกระโดด
All right.